In this video, I'm talking with Mara Tesler-Stein. Mara is an EMDR trainer and educator from Chicago, and she specializes in perinatal EMDR. She will talk about, among other things, how to work with pregnant women when doing EMDR. So, if you're an EMDR therapist, take a look. Mara Tesler-Stein, welcome to the Art and Science of EMDR, and thank you for being here.
Thank you for inviting me.
Mara,
Good to be here.
Mara, you're a licensed psychologist based in Chicago. You're an EMDR-approved consultant and EMDR trainer for the Institute for Creative Mindfulness. And you have your own training institute, the Touchstone Institute. I like that name. And you offer trainings in EMDR, both basic and advanced topics, specifically to clinicians specializing in perinatal and infant mental health. And you're also the co-author of 2 books for parents with premature babies and babies who spend time in the NICU. So I want to start by asking you, what is perinatal mental health?
That's a great question. So the perinatal period, first of all, ask 100 doctors and clinicians and you're going to get some variety of answers. But here's my definition, developmentally speaking. The perinatal period begins when families are beginning to try to conceive. It goes through that period, through a pregnancy, the pregnancy is achieved, through birth, and up to about 3 years post delivery of a baby. So we're really looking at this whole reproductive period, and it's an extended period, even into early childhood, and parenting that young child.
Yeah, it is. I would guess that it's longer than what most people think about. The perinatal.
Yeah. Common definitions will keep it much more constrained, but from a developmental perspective, the way that I think about the perinatal mental health and the perinatal period is we're really looking at a period of shifting identity, shifting relationships, lots of developmental stuff going on all kinds of levels.
Yeah.
So that's part of where I see that arc happening.
Yeah. So Mara, I'm wondering what made you interested in this topic.
It's an interesting kind of trajectory. I started my clinical career as a child and adolescent psychologist, and I was always interested in very early childhood. And it's funny, when I look back when I was a little kid, I thought I was going to be a neonatologist, ironically enough. And then, in my list of things I thought it was going to be when I grew up. So I was always really interested in infancy and did quite a lot of work at the Hebrew University with my mentor, who worked a lot in infant-parent interactions and that whole area. So when my husband and I started to think about starting a family, and it did not go according to plan, that interest, which had always been alive in me, started to perk up even more. And then when I became pregnant, finally with twins, which is considered a high-risk pregnancy, and then went into preterm labor at 24 weeks and spent 6.5 weeks in the hospital on bed rest, and then delivered them at 30 weeks gestation, which is 10 weeks early, and then they spent 10 weeks in the NICU. And as you can see, right, so the story goes on. They are almost 25 now.
Oh, wow.
Those babies.
Yeah.
Yes.
So you've been doing that for a while, that kind of work.
A long time. And so over the course of that experience, certainly during the hospitalization, it became very clear to me. I wasn't sure either there was something really wrong with me or the medical system was really missing something, because I kept asking for someone to talk to, and they sent me very nice social workers who said things like, "This must be so hard," which it is.
Yeah, and
that was about it.
Yeah,
that was about it. And they sent me somebody who played the harp, which was wonderful, but not what I was asking for.
Yeah.
And then that continued. And it was only after finding a community of parents of other premature babies and beginning to talk with them that I really started to heal. This was before I was trained in EMDR.
Yeah.
And then came to realize that there were resources that were needed that weren't out there. And so, I kind of got into this work both from the research, qualitative research end, and then also clinically, and those meshed. And it's been 24
Interesting.
years of this.
Yeah. Yeah. So I wanted to ask you more specifically how EMDR and perinatal work integrate, or how do you conceptualize perinatal related issues through the lens of the
Mm-hmm.
AIP model?
It's one of my favorite things to talk about.
Uh-huh.
So when you think about the perinatal period, I think it's really important to remember that it's a developmental period. Okay? So there's, just like early childhood,
Mm-hmm.
the adjustment, the development of becoming a parent to this baby
Right.
is a developmental journey. There are tasks that parents face on this developmental journey, and when the journey is disrupted, those tasks are challenged. So, in the research that I did with my co-author Debbie Davis over about 7-8 years, what we really found out was that there are 3 core tasks, developmental tasks, that parents face. And when you take those developmental tasks and you line them up with the themes that we see, these are themes, thematic issues that come up. When you line them up with the themes that we look at through the AIP lens, things like safety and vulnerability, things like choices, things like responsibility and shame, we really can understand conceptually, specifically, what developmental kinds of issues and dynamic issues, identity. So the 3 core tasks are developing a sense of self as parent to this baby, managing emotion, and managing relationships.
Yeah. So I'm wondering if we can talk even more specifically about targets. So, what would be examples of targets that you work with, with parents in that phase?
Yeah. So what I often hear from consultees and trainees when they're talking about their perinatal clients is, I don't know where to start. There's so much information. It's coming at me like a tidal wave. Right. So this rubric that I just described, I developed as a way to help people organize the themes in ways that help with target selection. Okay, so we can identify a theme. So let's say a parent, you're hearing a lot of themes around identity, around a parent who has a baby in the NICU. So I've talked to parents who say things like, my baby doesn't need me. I don't matter. What I do doesn't matter. What I say doesn't matter. So is that about my choices here, or my sense of self around being a parent? What's the negative belief? Maybe I don't matter. I don't matter. Float that back, right? So we always do float back. Even when somebody is coming in with a recent birth trauma, I always say, you have to know what came before. Because what makes this particular event or series of events really disruptive and traumatizing to a family, to an individual, it depends. It depends on what came before. It depends on what shaped the sense of self, right? It depends on where the injury has happened. So we always will float it back. So our target selection is going to start with the themes in the present moment. I don't really matter. I'm not good enough as a parent. It's too much. I can't handle it.
Yeah, which I'm guessing these are probably common themes that you see over and over again with
and over again
with mostly new parents.
No,
not
you
necessarily.
can see people where their third child is stillborn, or their third child is a premature baby, or their third child or fourth child has a medical complication, because it's a whole different world.
Yeah.
So much of what you learned if you were a parent already doesn't immediately apply. So the adaptive information networks that people have walking into parenting during a perinatal crisis don't necessarily immediately just fall into place. That's true of new parents also. Like,
Hmm.
we think we know what it's going to be like to be a parent,
Right.
right? I did my best parenting before I had kids too. We all do. But but
Yeah.
but so we learn. But the problem is that when you have a perinatal crisis, what you know about newborn babies isn't going to be necessarily helpful here.
Right.
What you thought and believed about yourself as a potential parent isn't necessarily helpful here. And if you've been a parent, you may not trust your parenting instinct,
Mm,
because what you do with a full-term healthy baby,
it's
you
not the
can't
same.
do with a premature baby or a sick baby.
Right.
And what about when the baby dies?
Yeah.
What does it mean to be a parent? So if you think about adaptive information here, you can see where the developmental issue is going to come in, right? Where's the adaptive information
Right.
going to be? Plus, you've got the rupture, you've got the disruption that has been caused, or the series of disruptions cluster here
Yeah.
from the trauma.
Thank you. That really helps clarify. Mara, I want to ask you something about a myth, a common
Mm,
myth about not treating
mm,
pregnant women with EMDR. Um,
yeah,
and I know I heard you speak about that before, but I wonder if you can give your own perspective on that, because I feel like, as an EMDR community, if we're not treating women who are pregnant who need treatment, we're not doing a great service to these
yeah,
women.
yeah, yeah. I think that's right. So, so this myth emerged out of a sentence or two in Francine Shapiro's textbook, which essentially says something. I don't have the quote in front of me, but says something about proceeding with caution
Hmm.
because of emotional activation. And from that has emerged real caution, concern, and avoidance of doing most phases of EMDR, though you'll hear people doing phase 2 work,
Hmm.
but no reprocessing. And then all kinds of assertions about, well, you can't do it in the first trimester, you can't do it in the third trimester, you can't do it for this reason or that reason. And all of that emerges out of something that is a heuristic,
Hmm.
that is a shortcut, a cognitive shortcut.
Right.
But with cognitive shortcuts also come cognitive errors.
Hmm.
And one very common cognitive error in medicine and mental
Hmm.
health is called the omission bias.
Hmm.
And this is all omission bias. Omission bias says it is worse to do something that I'm afraid will do harm than
Hmm.
to not do something. So that inaction is preferred over action,
Right.
even though inaction
Can
can
cause
do harm,
potentially even more harm.
could cause more harm. And in fact, in this case, that's the case.
Right.
Because when you look at the data of not treating or inadequately treating not only PTSD but depression and anxiety.
Hmm.
Depression and um, uh, postpartum depression, perinatal depression, and PTSD are very highly correlated.
Of
They
course.
co-occur
Yeah.
very highly. When we don't treat during pregnancy, we know we have a raft of data that shows the impact on the pregnancy. We see higher rates of preterm birth. We see
Hmm.
higher rates of gestational diabetes.
Hmm.
We see more complications. We see, not great prenatal care on the whole. We also see impact in infant development.
Hmm.
So we see difficulties in social development. We see impacts on cognitive development. We see this not just in infancy and childhood, but over time. So not treating is what we call toxic stress. What clinicians are worried about is in fact toxic stress, right?
Hmm.
We don't want to induce toxic stress.
Right.
What people need to understand is that what the research shows, so this is the other piece of this, is that trauma focused treatment, behaves not like toxic stress. It behaves like a different kind of stress that is important actually in
Mm-hmm.
pregnancy. We need some degree of stress in
Right.
pregnancy because it entrains the developing nervous system. And the unborn baby actually tolerates quite a bit of what we call adaptive stress, which is, I'm going to go in for an amniocentesis now. I'm kind of stressed about this,
Mm-hmm.
right? This elevates and then it comes back down.
Yeah.
Or buffered stress. So treatment, trauma focused treatment behaves like adaptive stress. And then a good treatment removes the toxic stress. It
Right.
clears the toxic stress. So it's not just that we shouldn't be avoiding EMDR during this
Mm-hmm.
period, but that we should be providing it.
Right.
Pregnancy itself is not a contraindication for any phase of EMDR therapy in any phase of pregnancy. Okay, so I'll say that again. Pregnancy itself is
Mm-hmm.
not a contraindication. Now, clinically, we still have to use all the same
Of course. Yeah.
assessments that we would use with somebody not pregnant.
Of course.
But the person who was ready to go into reprocessing phases last week, who comes in today and tells you they're pregnant, is still ready to go into
Right.
reprocessing.
Right. And the the EMDR work with a pregnant mom is not only for the benefit of the mom but also for the benefit of the fetus, because that
Correct.
toxic stress really causes a lot of damage.
Tremendous damage.
Yeah.
Really does. It really, really does. Long
Yeah.
term damage. So we really have an opportunity here to really to change that
Yeah.
in a big way.
Yeah.
And we see that the long-term effects when PTSD is treated in the pregnant person, we see that those long-term impacts go away.
Mm-hmm. Yeah.
So the same person who had a history of sexual abuse that is untreated through pregnancy, we see those impacts. If that person gets treatment, no matter when the treatment happens, we see a mitigation
Yeah.
of those impacts. It's really powerful.
Yeah, thank you, Mara. This is really important. I'm glad you're sharing this information. So, Mara, you have a training coming up, a
I
full
have a
training about,
few.
yeah,
Yeah.
about perinatal EMDR treatment. So I'm wondering if you can share a little bit about the training, when it's going to happen, how long, and what is going to be covered in the training.
Okay. So right now I have two advanced practice trainings on EMDR and perinatal mental health. The first one, which I just had in February, and actually I'm going to just open registration for another one at the end of June.
Mm-hmm.
It's called the Advanced Practice of EMDR for Perinatal Mental Health. It's a 3-day live course.
Mm-hmm.
It is also available online, self-paced. And that does a quick review of the AIP model because people come in from all training programs. So I want to make
Yeah.
sure we're all speaking the same language. Then I teach all about the 3 core tasks. I teach all about philosophies of care. We get into a lot of detail, a lot of granular detail about perinatal kind of situations through the AIP lens and through the 3 core task lenses. It's very comprehensive.
Yeah.
Then a new course that I'm teaching, which is coming up in the middle of May, which I'm very excited about, is is comes out of requests from people who didn't do the ICM foundational or basic training,
Mm-hmm.
but did my advanced training, who were like, but I want to kind of put it together the way that you put it together. And so what I do is I do a review. So it's like an EMDR review or reboot. It's called EMDR reboot, EMDR fundamentals reboot through the perinatal lens.
Mm.
So we do an AIP review and a quick 3 core tasks review. So we're all caught up. And then each phase, I teach how you do that phase and how you do it integrating
Uh-huh.
the AIP and the 3 core tasks. Then I show demo, and then we go practice with facilitation.
Nice. And
Then you come
when is
back and do
that
that
training?
with that's May. I'm going to say I think it's the 18th, 19th. It's the third week of May.
Mm-hmm.
It's 2 days
Mm-hmm.
with an optional third additional practicum and discussion day.
Okay.
So it's a Wednesday, Thursday, Friday.
Yeah.
And my facilitators are all certified. They tend to be my consultants in training, and they're
Hmm.
perinatal specialists.
Excellent.
And excited about it.
Okay. Mara, one more question for you. This is kind of like my personal interest of how we get
Sure.
better as EMDR therapists. How, if
Yeah.
I'm an EMDR therapist who just finished the basic training yesterday, what do I
Yeah.
do to get really good at what I do?
So, as most things are when I answer them, it's kind of a multidimensional answer. I would
Uh
say,
huh.
first of all, don't be alone.
Uh huh.
Find community, find consultants you can trust,
Mm hmm.
where you can be vulnerable
Mm
and say
hmm.
what you don't know,
Yes.
and where you can be safe to do that, and
Mm
find
hmm.
community of peers who are doing the same work.
Yeah.
And within that framework, practice a lot.
Yeah.
Even if you don't think you're going to do reprocessing with somebody, do phases 1 and 2 anyway, because it's going to help you conceptualize.
Mm
And
hmm.
I think conceptualization is the key. The method itself is not terribly complicated, but the conceptualization is more complicated, and that's where people get stuck in the middle of phase 4 or
Mm
5, 6.
hmm.
What do I
Right.
do? How do I understand this? What's happening here?
Yes. Okay. Mark Tesler-Stein, thank you so much for being here with me today and sharing this important information. And I look forward to talking to you soon again.
Thank you for having me. It was really fun.